I trained as an emergency physician and in public health. I'm not an infectious disease specialist, and I'm certainly not an Ebola specialist. My background is in humanitarian emergencies related to conflict and natural disasters. So I have not wrapped up a lot of miles on outbreaks. But 6 weeks ago or so, I was appointed Director of WHO Operations for the Ebola response at our headquarters in Geneva because of the scale of this crisis and the humanitarian dimensions that have been associated with it. So I thought before jumping in and talking about the outbreak and the response to date, I might just sort of walk you through a little bit about how we've structured ourselves at the World Health Organization to manage the outbreak. We essentially have three streams of work. We have the response itself, we have a strong line of work on preparedness, as well as research and development on new therapeutic agents. So in terms of the response, it's overseen by one of the Assistant Directors General at WHO. I, as has been mentioned, I'm managing operations out of headquarters. We have a team of about 80 infectious disease specialists, epidemiologists, logisticians, and administrative staff. And I also have two counterparts based in a big UN operations base in Accra, Ghana. And collectively, we provide the technical and operational support to the response in the affected countries. And as I said, we also have a lot of work going on preparedness for those countries that have not yet been infected so that they can prevent and prepare for that eventuality, as well as all the exciting work on new vaccines and therapeutic agents. And I'll make some brief remarks on both of those activities a little bit later. So for those of you like me who didn't know a lot about Ebola previously, maybe just a quick whip through on what the Americans would say would be Ebola 101. Ebola is a viral hemorrhagic fever. It usually presents clinically between 2 and 21 days after exposure, and the symptoms initially are pretty non-specific. They feature general fatigue, malaise, myalgia, headaches, and so on. And as the disease progresses, it can result in severe vomiting, diarrhea, hypovolemic shock, and hemorrhage. It's a very serious illness. Mortality rates, when left untreated, can be as high as 90%. In well-managed clinical facilities, the case fatality rate can be as low as 35%. There's a lot of misunderstanding and myths around Ebola and the way that it's transmitted. Importantly, I think it's important to note that it can only be transmitted from an infected individual once that individual is symptomatic. It is primarily, it is spread through exposure to body fluids, particularly vomit, diarrhea, and blood. There is no evidence that it is spread through airborne or droplet infection. And I was quite taken aback a few days ago when I was talking to a very experienced physician here in Australia who was expressing concerns that was the mode of transmission. So I think it's very important that we realise that the risk of transmission, even for most people working in Liberia right now, unless you are working in a clinical healthcare setting or involved in burials of dead bodies, the risk of transmission is very, very low indeed. So what about this outbreak? It wasn't really recognised as such until until cases were identified in a rural part of Guinea in West Africa in March this year. In retrospect, we realise now that the first cases really developed around December in the same region. And there are a number of reasons why it was slow to be identified. One reason was that the disease, Ebola virus disease, had never occurred in West Africa before. All previous outbreaks had been in places such as the Democratic Republic of Congo, South Sudan, Uganda, and so on. So this was a new disease for that part of Africa. It also presented similarly to other diseases that are prevalent there, such as Lassa fever and yellow fever. So, in fact, it started in a tri-country area in Guinea, near the borders with Liberia and Sierra Leone, which is populated by a tribe that straddles those three borders, the Kissi tribe. And there's a lot of trade and a lot of communal and family movement in that region. So the disease was spreading while not being recognised. And very, very quickly after March, it was recognised that it wasn't only in Guinea, but it was across the border in Sierra Leone and then in Liberia. And then it escalated for reasons that I'll explain a little bit more in a moment. But the dynamics of this outbreak have been different from all other previous Ebola outbreaks. And it got to a point where in August, the World Health Organization, based on recommendations from its emergency committee, convened under what is called the International Health Regulations, an international treaty, declared the Ebola outbreak a public health event of international concern. So what does that mean? That's actually a specific designation given under the International Health Regulations for a public health event that is of substantial global interest and risk. And this is only the third public health event in history under the IHR that's been declared a public health event of international concern, the so-called FAKE. The others were the pandemic flu in 2009 and the re-emergence of the polio virus in the Middle East earlier this year. So it's gotten a lot of attention, but by that stage, it had really gotten away from us. It had really started to spread. And since then, 8 countries have been affected. The 3 main affected countries, again, of Liberia, Guinea, Sierra Leone. The disease got into Senegal, 1 case, rapidly detected, rapid response, it was shut down. And Senegal now has been declared Ebola-free. Similarly, there were about 20 cases in Nigeria. Again, through good leadership of the government, with strong international support, well detected early, good response, shut down, and now Nigeria is Ebola-free. And as I'm sure you're all familiar, now there have been cases in the United States and Spain, again, well controlled, well contained in those 2 settings. But of major concern, in the last couple of weeks, we've had cases identified in Mali with 2 different chains of transmission. And so there are rapid response teams that have gone in there and again, trying to implement these rapid control measures so we can contain the outbreak and make sure it doesn't spread beyond the affected areas and of concern into other neighbouring countries. So, all previous outbreaks, for, again, those of you who are less familiar with the virus, all previous outbreaks had been in rural settings. They'd involved maybe 50, several hundred cases. They'd only ever involved 1 single country. Ebola has never crossed, during a given outbreak, has never crossed the border into a second country. And there are well-known control measures that, once implemented, can contain the outbreak pretty efficiently and very effectively. So, for example, we've had an unrelated Ebola outbreak in the Democratic Republic of Congo in the last few months, as you may be aware. There are about 60 cases. Again, control measures implemented, contained. That outbreak has now been stopped, and within 2 days, Congo will be declared Ebola-free. This hasn't been the case with this outbreak. As I mentioned, all that transmission and movement across the 3 borders, the delay in recognition, now the outbreak has gotten into urban environments. This has never happened before. So in the overcrowded, impoverished settings of Monrovia in Liberia, Freetown in Sierra Leone, and Conakry in Guinea, it's really established itself, and it's been difficult to control in those settings. So here we are, West Africa. This is the tri-country area that I mentioned, and this has really been the epicenter of the outbreak. This is a pretty tough neighbourhood, mired in underdevelopment, poverty, conflict, political instability for decades. Senegal, again, and Nigeria, both Ebola-free. But here's Mali, and very significant concerns, and again, rapid ramping up of our response at the present time, given the 6 cases that have been documented there. So as I said, it's a pretty tough neighbourhood, West Africa. A lot of conflict in recent years. Guinea itself has had a lot of political instability, attempted coups, a lot of civil unrest and civil conflict. Liberia in 2005 emerged from 14 years of civil war, and actually has made some pretty remarkable progress on a number of fronts. Ellen Johnson Sirleaf, the president of Liberia, as many of you may know, was awarded the Nobel Peace Prize in 2012 for her wonderful work on post-conflict reconstruction and peace building. and Sierra Leone. Sierra Leone in the early part of the last decade emerged from 11 years of civil war. So whichever way you cut it, all the developmental indicators and health indicators are pretty poor in these countries. The United Nations Development Programme has what's called the Human Development Index. What it basically does is it ranks all the countries in the world on their level of development, looking at economic indicators, social, educational, health, and so on. There are 187 countries that are ranked. Sierra Leone comes in at 183, so the 5th poorest country in the world. Guinea at 179, and Liberia at 175. Sierra Leone has the worst under 5 or child mortality on the planet, and it has one of the worst maternal mortality rates. Liberia, in fact, has done a remarkable job in post-conflict health system reconstruction. All the coverage indicators have increased, all the outcome indicators have decreased. And in fact, child mortality in Liberia has decreased at a faster rate than any other country in Africa. And Liberia set itself a pretty high target of reaching what's called Millennium Development Goal 4 for child mortality, and reached it, which was an exceptional achievement. But now all this is starting to unravel in the space of a number of months, all this great work on reconstituting the health system. Guinea itself, again, poor developmental indicators and poor health indicators. I want to put things in relation to the outbreak in perspective. Right now, the global humanitarian community has never been so overstretched. Currently, across the world, there are more people in need of humanitarian assistance than at any time since those records were kept. Prior to the Ebola outbreak, there were an estimated 105 million people globally needing humanitarian aid. There are more refugees in the world today than at any other time since immediately after the Second World War. There are more internally displaced people as a result of conflict in the world today than at any time in history. So it's been a tough 12 months to 18 months for the humanitarian community, and now to have a multi-country Ebola outbreak with huge humanitarian dimensions has been very, very challenging. The WHO, we have a way of grading emergencies. We have what's called a grade 3 emergency, or as is known in the UN system, United Nations system, a level 3 emergency. That is a major humanitarian catastrophe that requires all hands on deck. Really, the A team has to go in and manage that. So, for example, the Asian tsunami in 2004, the Haiti earthquake in 2010. Usually we'd expect one of those crises every 2 or 3 years. Right now we have 5 of them ongoing at one time. In the last 12 months we've had 6. So we have Syria, Iraq, South Sudan, Central African Republic, and now the Ebola outbreak. And in November last year, of course, we had the Philippines emergency. So the international humanitarian community has never been so overstretched. And the response, this response is our operations in the Ebola-affected countries. We're competing for all types of resources with all these other emergencies. Those 5 level 3 emergencies, we have another 8 what we call grade 2 emergencies. Ukraine, Congo, Myanmar, Somalia. In Yemen today, there are 10 million people in need of humanitarian assistance. Never hits the radio waves in this country. So this is the context and environment in which we're trying to launch a major operation in these 3 countries. Okay, so that's a little bit of an intro to the disease and the regional and global context. So what's happening with the disease? Well, maybe quickly whip you through some of the epidemiology and the figures. To date, since the outbreak started, we've had about 15,000 cases across the 3 main affected countries. Now, this almost certainly represents an underestimate. It could be as high as 20, 25, even 30,000. We usually categorise cases as to whether they're confirmed. That means that there is an actual laboratory diagnosis. Probable, which means that there's a good history or clinical presentation, even though we don't have a laboratory diagnosis. Someone, for example, who's died with all the symptoms of Ebola. And then suspect. These are cases that fit the criteria, and we're waiting for confirmation. About 2,000 cases have occurred in Guinea. Liberia's documented the largest number, around 7,000, and Sierra Leone's had about 5,000. So The biggest previous outbreak of Ebola was about 500 cases. Total number of deaths, this is definitely an underestimate, but our figures indicate around 5,500 deaths. We know this is an underestimate because when we look at clinical and settings, the case fatality rate, that is the proportion of people who have the disease that die of the disease, is around 70%. In some of the better hospital circumstances, it's around 60% right now, and in some of the smaller clinics, it's around 82%. I'm going to slip over this slide because I'm going to address those issues on another slide. So here's a heat map that gives you a sense of where geographically the disease is most prevalent. And what this map shows you is a real challenge. The disease is present in every district in Liberia, every district in Sierra Leone, and more than half the districts of Guinea. So again, a challenge to launch a major operation. This is the three-country region that I've mentioned a couple of times, which has really been at the epicenter of the outbreak. And then it spread. These darker areas, of course, the areas with the most number of cases, the capital city of Monrovia down here in Montserrado County in Liberia, Freetown, Sierra Leone, and Conakry. Of big concern, we're starting to see an escalation up here in the northwest of Sierra Leone, and more recently here in Macenta. The disease is also beginning to escalate up here in Sikuri, in northern Guinea, and from there it has spread into Mali. Again, the implications of which I mentioned earlier. Great need to get in there quickly, shut it down before it spreads. Of concern, there are cases along the border with the Ivory Coast. There are districts along that border where cases are being documented. And so we are working hard to improve surveillance here and build the capacity of the Ivorian Ministry of Health and local officials to detect and respond early. So far, we haven't detected any cases in Ivory Coast, so we hope and pray that that remains the case. What this represents is the number of cases the last 21 days. And it really gives you a sense of the dynamics of the disease. So the bigger yellow dots, of course, represent the high number of cases. Encouragingly, Lofa County up here in northern Liberia was really at the epicenter of the outbreak earlier. But because of good response from the local community and international partners, we've been able to implement effective control measures. The community has stepped forward with some real behavioural measures because this is a disease that is spread through various behaviours, and we've been able to substantially reduce the number of cases there. But again, it's starting to escalate here, and so we have to be nimble and effective in redirecting our efforts and our resources to evolving hotspots. So this is the epidemic curve, and this is the number of cases by week since the onset of the outbreak. And it's the cumulative figures across those three main affected countries. And back in September, we were extremely worried because of this exponential increase. And that exponential rise gave rise to some of the projections that you may have heard about, projections from one or two public health agencies that into the new year we could have as many as 1.4 million cases across the region. Now, those projections did not come from WHO, I might add. We only projected out as far as about 6 weeks, but our own projections were around 5,000 to 10,000 cases per week by the first week of December. Fortunately, we've seen a bit of the heat coming out of the outbreak and a bit of a levelling off on the incidence. And that is, again, because of better efforts by the local community. It's been remarkable the way that some of these communities have recognised how the disease is spread, even in these remote rural settings. In some of these communities, the leaders have identified infected individuals early, isolated them, and then rapidly transferred them to health facilities. Through great partners like Doctors Without Borders, the International Rescue Committee, and so on, we have been able to educate communities, scale up access to treatment. And so again, in sites such as Lofa County in Liberia, Kenema and Calhoun districts in Sierra Leone, we've been able to reduce the number of cases. One of the other really important measures is ensuring safe burials. And again, that's contributed to this flattening. Interestingly, a dead body will transmit the disease more readily than an infected individual. And there are some traditional practices and cultural practices, particularly in that tri-country area, that contribute to the transmission of the disease. Such, in that part of the world, the most important day of your life is the day that you die. So there's a big celebration, the body is prepared, it's washed, people embrace the body, they kiss the body, they prepare it prior to final burial. It's an incredibly important practice for these communities. And then so for a bunch of white guys to turn up in funny looking suits and say, hey, you can't do that, it just doesn't work very well. So the way that we engage with communities is critically important to controlling the disease. And so we have actually a small team of, or small army I should say, of anthropologists helping us to understand the social dynamics and the practices within these communities that can contribute to disease transmission. So what we have done is we've done a lot of work on communicating the importance of safe disposal of bodies in a very dignified way. And we've also trained a large number of burial teams. So guys have to suit up and ensure that the burials are done not only safely, but in a dignified way that is consistent with local values and practices. So all those measures have contributed to this. But the picture is somewhat different across the three countries. Where we've made the most progress is in Liberia, where the outbreak just shot up, and now, again, in places like Lofa County, Montserrat County, we're seeing significant reduction, but we're still not on top of it. In Sierra Leone, the picture is rather different. Again, it's that northwest area where the disease has gotten away from us again. Whereas in the east of the country, we're seeing a reduction in the number of cases. In Guinea, it's a different picture altogether. We've seen this sort of grumbling along, bit of an increase here, but a bit of a levelling out. So the dynamics of the disease are somewhat different in the three countries right now. And so we have to, again, be agile and flexible in the way that we implement our response. So a lot of data, a lot of figures, statistics, epidemiology, and the danger of that, of course, is that you lose the human dimension of the disease. Very concerningly is the number of infections amongst healthcare workers. To date, there's been over 560. The majority of those have died. As Tanya said, I had the privilege of working in Liberia for 2.5 years. 2 of my colleagues have died of Ebola. And in Liberia, there's 1 doctor per 100,000 population. So the Liberian Medical Association is a very tight, small and tight-knit community. There's about 150 doctors in the Liberian Medical Association. So you can imagine, the death of 1 or 2 or 3 colleagues, it's been demoralising for the health community. 4% of health workers in Liberia have been infected. But they're incredibly resilient. I was there a few weeks ago, amazed by the way that they are addressing the response and really determined. So incredible work being done there under all those difficult circumstances that I've tried to explain earlier. But it's not just health. This is not only just a health crisis. For a long period of time, almost all health services have been shut down in Liberia and large parts of Sierra Leone. Right now, there's only about 46% of health facilities open in Liberia. All schools in Sierra Leone and Liberia have shut down. This is an orphanage school in Liberia where my wife worked for 2 years. And so there are 2 aspects here. Again, these kids aren't getting an education right now and haven't done for several months. University students. When I was in Liberia a few weeks ago, I saw university students who I know, they're not allowed to play sport. Their education has stopped. I asked them, how do you spend the day? Well, just sitting around, but trying to stay safe. So again, we can't lose sight of the human impact and the broader social and economic impact. Sierra Leone's economy was growing at a rate of 8% until this outbreak. So the outbreak's taken off almost 3.5% of its economic growth, and similarly in Guinea and Liberia. There are no doubt going to be significant political ramifications of the outbreak. Already politicians, opposition parties and so on are trying to exploit the situation, criticising the governments for their response and so on. So there are much broader impacts than just in the health sphere. And there's a lot that could be said about all those issues. Agriculture, disrupted. Food security, a problem right now. Now we are bringing food aid into these regions, particularly the most affected countries, because farmers aren't going and tilling their land and so on. There are a myriad of issues here. When I was in Liberia a few weeks ago, the special advisor to the president on Ebola said there has been nothing in the history of this country, not even the 14-year civil war, that has impacted every aspect of life so pervasively as the Ebola outbreak. Okay, so again, sense of a little bit about Ebola 101, epidemiology, the way that the outbreak has progressed. What are we doing about it? So I'd have to say, as I've kind of implied earlier, that the outbreak really, the dynamics of this outbreak, given the way that it spread, really did outpace our strategy and response. When I was in Liberia, several weeks ago, I met several times with Doctors Without Borders, who have done more on the response side in providing clinical services than any other agency. And 3 times I met with the head of Doctors Without Borders there, and she said, "We're changing our strategy every day." It was escalating that quickly. I think we've got our arms around it a bit better there now, particularly in Monrovia and Montserrat. But again, give you a sense of the seriousness of this particular public health event. The Security Council of the United Nations has only addressed 2 health issues in its history. One was the HIV/AIDS pandemic, and the second is Ebola. So the Security Council, a couple of months ago, discussed Ebola and issued a Security Council resolution where it declared the current outbreak as a threat to global peace and security. Because if this outbreak isn't under control, those governments collapse, there is violent conflict, economies collapse, the risk of spread beyond the borders of those 3 countries into other parts of Africa and beyond are very significant. So the Americans are taking it so seriously, they've deployed 2,900 troops, not for peacekeeping, but for their logistics and operational capacity. And they're actually building Ebola treatment centres, essentially field hospitals in Liberia right now. Similarly, the Brits have sent in 750 troops into Sierra Leone for exactly the same reasons. And most recently, the United Nations has set up what's called the first ever public health mission, UNMIR, the United Nations Mission for Emergency Ebola Relief. So you're all familiar with peacekeeping missions, of which there are about 18 in the world today, including one in Liberia and in Afghanistan, Congo, South Sudan and so on. Also, the UN has what's called political missions, and they go in and that's when they have high-level political representatives in a country to contribute to peace building and so on in countries that have emerged from conflict. So they're the classic 2 types of missions that the UN engages in, peacekeeping and political. This is the first ever public health mission. And what that means is all the resources and assets of the UN are coming together under single leadership and a command and control structure. It has some features of a military operation now. So WHO, UNICEF, the World Food Programme, other UN agencies, now we are all under UNMIR. And the head of UNMIR, the main operational base is in Accra in Ghana, the head of UNMIR is what's called a special representative of the Secretary General. So he reports directly to the Secretary General on Ebola response. And his office sends a daily update on the response to the Secretary General in New York. And there is a live video briefing weekly. So that's how seriously we're all taking this. So UNMIR, this brand new UN structure, we're all part of it. And we are all coming together with a common goal, strategy, plan, and implementation. So our goal is to shut this thing down in the region within 6 to 9 months, to stop it spreading beyond, and as far as possible, mitigate all those other secondary effects that I mentioned earlier. We have 5 main objectives, what's called the STEP approach. stopping the spread or the transmission of the virus by improving surveillance, identifying and isolating people early, treating those infected in designated health facilities, what we are calling Ebola treatment centres and community care centres, ensuring access to essential services, again, making sure that pregnant women have a place that they can go and deliver, trying to restart vaccination programs for kids, trying to restart schools and agricultural services and food security. Preserving stability by trying to engender trust amongst the local community in the government officials and supporting them as much as possible, especially in their emergency operations centres. And preventing and preparing for spread to other regions. So the whole UNMIR apparatus, all the members and our non-governmental organisation partners have come together around these objectives. So the good news is, while it sounds, while I may have painted a pretty dire picture, the good news is we know what works. We can stop this thing, and through application of clear public health measures. So these include, again, the surveillance, the case finding, the contact tracing, when there's a case, identifying the people who've may been exposed to that person and monitoring them. Case management, again, in these treatment centres. Community engagement and social mobilisation, I've already explained how important that is. And the safe and dignified burials. So these are our 4 main public health measures, or as UNMIR describes them, lines of action. But we have to scale up on a massive level. And to do that, to get this across moving across these 3 countries, we need huge logistic support. We need human resources on a scale that has never been deployed for any outbreak in history. We need to make sure that health workers, because it's going to be local health workers who do most of this work, that they get paid. That is no small feat when you are working in a remote rural part of Liberia or Guinea. So putting in systems to make sure that health workers are paid regularly and so on, and not only health workers but other humanitarian responders. Information management, a big issue. I mean, some of the data that I showed you earlier, there's a lot of questions around the accuracy of that data, and we still have to make sure that we have that we strengthen our information management systems. So we've all signed on to these 4 lines of action and these enabling functions, what we call the enabling functions. And to do that, what we did is start early last month, around I think it was the 12th and 13th of October, we all convened in Accra, all the UN agencies, to work out what needs to be done. And we undertook a big operational exercise. We did some modelling. A guy on my team led that process. And we identified 45 priority sites across the 3 countries. We said, okay, if we need to implement those 4 measures across those 45 sites, this is what we need. This is how many staff we need. This is how many vehicles we need. These are the air assets that we require. This is the accommodation we need. This is the volume of personal protective equipment we need to get out there. These are the number of Ebola treatment centres we need. These are the number of community care centres. And we mapped it all out. But as I've explained, the outbreak is changing. So we have to be flexible in the way that we implement this. And so now we're trying to implement, we're trying to scale up, and we're making some progress, but we're not close to where we need to be. For those 4 public health measures, for all those enabling functions, there's been a lead agency identified, WHO, we're the lead on case management, we're the lead on surveillance, case finding and labs. And then we've got other partners. Now, these are mainly UN partners, but we have a lot of NGO partners as well, non-governmental organisations, and they're playing a vital level. But the important thing to remember is the governments are in front, the local communities are in front. And again, without the local communities and the governments, we won't get this job done. And we also now have the added advantage of having the US and UK militaries and their logistics assets, which have been enormously helpful. We also set ourselves some key indicators to track and targets. So we said at 30 days we want to be here, 60 days we want to be there, and 90 days we want to be there in terms of field presence, staffing, logistics, operations. We haven't met our targets because it's been more difficult than we expected, but we are making progress. And I'll show you a couple of results. We also committed to what we call our 70-70-60 targets, which means that by December the 1st, after 60 days after meeting, it wasn't 60 days after meeting, but the clock started ticking for us on the 1st of October. And by the 1st of December, we want to make sure that 70% of identified cases are isolated appropriately, and 70% of burials have been conducted in a safe and dignified manner. So how are we doing? So-so. So what we've determined is we need around 4,000 Ebola treatment centre beds. In fact, that number of beds will probably decrease. We're just revising some of our projections right now because we've seen a flattening of the outbreak, but we have 26% of them in place right now. We have 2% of the community care centre beds available. We'll probably need fewer. So the denominator, our targets will probably decrease, so these figures will probably increase. We've done well in scaling up access to laboratories. We've deployed about 15 through our partners. Great work from partners from across the globe. We've got about 15 field labs on the ground. So just about every district is about 24 hours away from, is no more than 24 hours away from a lab. And that's been very, very important in the response effort. The percentage of cases isolated, our two big indicators, the percentage of cases isolated and the percentage of dead bodies managed safely and culturally appropriately, we don't actually have our percentages yet. The data here isn't fully available yet. It's coming online. We do have some data. In fact, the data that we have suggests about 87% of cases are isolated in a timely manner. Frankly, we don't believe that. So we're not propagating that information yet. But we hope by next week we just had a big meeting in Accra, our information management specialists, and we are strengthening that overall management system. So again, part of the big scale up that's undergoing. We're pretty confident about close to 5,000 of bodies have been managed somewhat appropriately. The good news is that in a number of the settings we are getting out and we're tracking down the contacts and monitoring them, and that's working more effectively. And our resources are okay. For WHO, we need about $260 million to do our part of the job. We're about 72% funded right now. Our other UN partners, they probably need about $1.5 million. And we have, well, the overall effort, I should say, needs about $1.5 million. And we're well short of that at the moment. But we're confident that the donors are giving some positive signs. But again, we're competing for the response dollar just the way as our operations in Syria, Iraq, South Sudan are competing for that same humanitarian dollar. And right now, global humanitarian needs are around $18 billion, far higher than at any time in history. So, and donors don't have that much cash to pass out. So what they give to us for Ebola may be taken from Central African Republic, may be taken from Somalia, may be taken from Gaza. Just to give you a sense of some of the challenges we have, just a couple of words perhaps on the Ebola treatment centres. So these are essentially purpose-built field hospitals where we would treat patients. We estimate that across the 3 countries we need 56. We've got 19 of them operational right now, and we have commitments from international partners to. The US and UK militaries, I might add, they're going ahead and building these things. You know, build them and hopefully someone will come in and run them. We haven't got commitments for every one of these Ebola treatment centres. But we have partners who've said, yep, we'll run an Ebola treatment centre for you if someone will build it for us. We've got 22 other partners doing that. So as soon as in the next couple of weeks, we'll have a few more of these Ebola treatment centres up and running because they're being built by the World Food Programme and the militaries, and then these operational partners will come in and run it, put clinical staff in there, manage it. But we still have a gap of 15. We still have another 15 for which we haven't identified an operational partner. Give you a sense of the challenge here. You know, prior to this outbreak, the largest Ebola treatment centre ever was run by Doctors Without Borders, 40 beds. Some of these now have 100 to 200 beds. And essentially the only organisation on the planet that's ever run an Ebola treatment centre is Doctors Without Borders. Now we're asking the International Organisation for Migration, the Red Cross, and so on, all these other NGOs to come in and run these 100-bed facilities when they've never done anything like that in their history. So that's a real challenge, and it's really heroic, in my view, that these organisations are stepping forward and doing this. So it's been a challenge, but they're coming online and these are being pretty effective. I might add that most of those healthcare worker infections that I mentioned before, they're not occurring in these settings. They're occurring in private settings, because when people get sick, they go to the nurse who lives down the street, or they go to the private clinic. That's where about 90% of the healthcare worker infections are happening. These are pretty safe places to work because they've got strict protocols and so on, and the right infection control measures. So some of the challenges, I mean, the good news is we know what works, we're scaling up, we're all, you know, we've got a common plan, we've got common objectives, we've agreed on the targets, you know, we're in it together. That's the good news. And we know what works. Given the resources, we're pretty confident we can get this done. But we've got all those challenges. The scale, this is bigger than anything, you know, we have to build out across the big geographic area. Having the sufficient operational partners, I've just shared the challenge that we have with the Ebola treatment centres, but it goes beyond that. Do we have enough partners to manage the safe burials? Do we have enough organisations to do the community mobilisation, and to run the labs and so on? Identifying human resources is a challenge. Hands up those of you who would like to go to work in Liberia or Sierra Leone right now. A lot of the people, yeah, great. I'll give you my email address. You know, again, a lot of people will just take themselves out of the mix already because it's Ebola. And at the same time, we're competing for staff to go there as opposed to Syria, Central African Republic, and elsewhere. So it's tough. Medical evacuation, big issue. The good news is that every international staff member who's been infected with Ebola has been medically evacuated in a timely manner. But we still haven't got a 100% guarantee that we will medically evacuate if you come and work for an NGO. WHO, we can guarantee it. If you come work for us, we can guarantee it. We've done a lot of advocacy with the European Union. We've got planes that'll transport you. The rate limiting factor is identifying hospitals that'll treat. So every medical evacuation has been arranged on an ad hoc, one-on-one basis. The good news is that it's worked every time. But if you come to me and say, okay, I want to go and work for, you know, Doctors Without Borders, can you give me a 100% guarantee I'll get medically evacuated? We can't give you that guarantee right now. There's also been a problem about the quality of healthcare in country. The good news is that the US military and the UK militaries have built purpose-built facilities in Monrovia and Freetown, and so they will provide good Ebola care and hopefully other care as well. Information management, I've touched on that. Funding, I've touched on that, and the flexibility issue. So that's a quick whip through, you know, some of the issues related to the response. Well, what about those countries bordering Liberia and Sierra Leone and Guinea? And what about those countries that have direct air links? And what about Australia and the United States and so on? What's going on there? Huge efforts on the preparedness side. I mean, while Ebola exists in West Africa, no country is 100% safe. That's not an overly dramatic thing to say. Travel will occur, even if we tried to. I was asked in an interview the other day, can't we just quarantine those 3 countries, close the borders? You can't do it. It just, it wouldn't work. So our best option is to attack the outbreak at its epicenter, while at the same time building the capacity of countries, particularly those neighbouring countries, to detect and respond as necessary. So there's been distribution of a lot of technical guidelines and tools and so on that's routinely been done. We are undertaking 15 preparedness support missions. We've already been to about 6 or 7 countries. In fact, we had a team on the ground when the first case was detected in Mali. And again, they were able to kick into gear. So what those teams are doing is they're going in, assessing capacities that countries have committed to develop under the international health regulations that I mentioned earlier. Every country on the planet has signed on to the international health regulations. Every country has agreed to build their capacities to prepare for, detect and respond to public health events. So we're not starting from scratch here. We're going in and building on some of these measures. 15 priority countries, as I mentioned, but there are other visits going on. Our colleagues in the Pan American Health Organization are doing visits to every country in their region. Our colleagues in our regional office in the Middle East is making visits to all the countries there. So a lot of work on preparedness. Some of the exciting developments are in the research and development field, where I have had much less involvement, but there are big efforts right now to fast-track new diagnostics and therapeutics. Currently, we have we have 2 vaccines under trial. Usually it takes several years to develop these types of interventions, but we're hoping to fast-track, if they're safe and efficacious, and hopefully have a few of these new tools online within 6 months or so. And maybe if some of these vaccines, 1 or 2 of these vaccines is again, safe and efficacious, maybe online even a bit sooner. So trials going on right now with the vaccines. Convalescent serum, taking the plasma, the serum from the plasma from survivors and infusing it into other infected individuals is an effective way of managing Ebola. And as you may have heard, it's been used in a couple of the expats that have been infected. But it's a complicated process. The health systems, obviously, in these countries don't have the capacity to do that. But the Bill and Melinda Gates Foundation have donated some equipment right now, and so they're starting to provide, in the coming weeks, hopefully we'll have that measure available to some degree in the affected countries. There are some exciting new novel drugs. You may have heard of ZMapp, that's the monoclonal antibody that's been used apparently successfully in a couple of the Americans that have been infected. And there are a number of other therapeutic agents that are being explored right now. But none of them, we won't have the capacity to produce any of these, the vaccines or any of these drugs, at scale anytime soon. So all our efforts in the response and those public health measures are based on the assumption that we won't have any of these new interventions online in the foreseeable future. So I think, perhaps wrap up, maybe to leave you with a couple of takeaways. Again, this is the largest and most complicated outbreak of Ebola in history. As I work with I have the privilege of working with a lot of senior global health figures, and every one of them has said this is the most demanding crisis they've ever dealt with in their lives. We're not yet fully under control. We've made progress in certain areas, and we've got to scale up. We know what works. We have the tools available to us, but we still need a major scaling up to manage the outbreak, and with more resources. I'm not just saying this, I'm not being flip. We can get the job done if we're given the resources. We've got a lot of expertise, some really brilliant people working on this. Again, I'm just the emergency management guy, but the technical people working on this are really, really exceptional. And at the same time, we're going to keep on with the preparedness efforts and the development of these new experimental therapies and vaccines. So I'll leave it at that, and thank you for your attention and interest.